Cases. Next presenter, Dr. Ayan Mohanto. He is also from Disha group of eye hospitals, and he's an excellent refractive surgeon. Everybody is an excellent cataract surgeon, but apart from that, he's an excellent refractive surgeon also. So he's going to share, I think, some of his problems with refractive surgeries.
One problem.
From the bouquet of so many problems, you're going to share only one?
One.
Only one, okay. So whenever you are ready.
Yeah. So thank you, Surjo, for giving me this opportunity. So I'll be talking on corneal calamity. So there was a 21 years aged unmarried female patient who presented with stable high myopia. She had no history of allergic eye disease in the past. Her refraction in the right eye was minus 9.5 with minus 2 at 15 degrees. And in the left eye, it was 10.5 with minus 2 at 160 degrees. Best corrected visual acuity was 6 by 6 in both the eyes, and patient was interested in removing her glasses. So we did oculizer, every parameter looked normal. There was no elevation pattern changes. The topography was normal. The pachymetry was good, and in both the eyes. So this pre-op oculizer showed a cornea with right eye pachy of 545 and the left eye was 538, the thinnest local area. Normal front and back elevation patterns. 110 micron flap was created using a femtosecond laser. Ablation was done for minus 9 and minus 1.75 CL in both the eyes. And the target residual bed was 306 microns in the right eye and 301 in the right eye, 301 microns in the left eye. So this was the treatment pattern. You can see in the, here is the actual treatment we did with 110 microns flap, and there was a residual stroma of 306 microns in the right and 301 microns in the left eye. And we did a same treatment, slightly undercorrected in the left eye. So immediate postoperative period was uneventful. The patient was evaluated on the first post-op day and 7th post-op day. Subsequently, she was lost to follow-up. Though she was asked to follow up after 3 months, she didn't come. So after 18 months, the patient suddenly turned up with dimness of vision in the left eye since last 6 weeks. Clinically, there was frank keratoectasia was noted in the left eye. The uncorrected vision in the right eye was 618 and the best corrected vision in the left eye was 660. Oculizer was advised. So in the right eye, if you can see, the topography has changed quite a lot. In the right eye, there is quite a subsequent amount of back elevation change in the However, the front elevation looked more or less normal with slight few elevated spots in 1 or 2 areas. In the left eye, there was a gross change in the posterior elevation. You can see in the front elevation pattern, you can see almost plus over here. If you can find the plus 21 in the some region, it's plus 46, plus 56. Oh no, here is plus 71. Sorry. And in the back elevation, it's almost more than 200 microns. So the right eye pachy was down to 394, and with a central posterior elevation change of 26 microns. In the left eye pachy was 267 microns with a keratoconus score of 4 and central posterior elevation change of more than 200 microns. After 2 days, a hypotonic C3R was done in right eye. For left eye, we were puzzled what to be done, DALC or RGP, contact lens or a miniscleral lens. So after consulting with experienced refractive surgeons all over India, it was decided that even in that thickness, we can go for a C3R with a sub 400 protocol. But the problem was that the patient lost to follow-up because he lost faith in me and didn't turn up. On asking over phone multiple times, I came to know that she was advised by some ophthalmologist colleague of mine, RGP trial, and she was happy with that. Patient stopped answering my phone. Since August 21, the patient didn't turn up. So that's it.
Your patient behaves a lot similarly like my wife, stops answering phone calls after you piss them off. So my question is that is there any way to have predicted this?
I don't think so. The only, yeah.
Just want to ask that is there any upper cutoff limit beyond which you will not do a LASIK procedure even if the residual stromal bed is good enough?
See, after this, I mean, residual stromal bed is normal. The FDA says to keep it as 250, but here we have kept it 300. And after this, I have changed my criteria a lot. I mean, over 8, I don't go for any sort of LASIK, even if the corneal thickness is good.
And what is your current residual bed? 500. you try to keep. Anyway, excellent.
Yeah. Yeah. So it was done by cornea surgeon. I mean, not myself.
Different corneal surgeon. Different.
Yeah, different cornea surgeon.
Because you are also a corneal surgeon.
No, I used to be, but not now.
After this LASIK, you stopped. Anyway, thank you, Dr. Mohanto. Excellent presentation.